A 25-year-old patient, type 1 diabetic, comes to the emergency and the blood gas is done. The pH is 7.26, glucose is 290, bicarbonate of 16, anion gap of 16, and urine ketones plus. Probably what is the diagnosis? I think this is like a very easy question, right? Diabetic ketoacidosis. So, by definition, diabetic ketoacidosis should have the presence of all of the three. One is hyperglycemia and the blood sugar should be above 250. Patient should have ketosis, so ketones has to be there, and acidemia, which is pH of less than 7.3. So these are the three basic characteristics that one should have. Then only you can label this patient as diabetic ketoacidosis. Precipitating events, the most common two precipitating events. One is infection. So this infection could be consolidation, urinary tract infections. Generally, they would have symptoms of gastroenteritis. That is the more common precipitating events. So gastroenteritis and sepsis of another origin. The second most common etiology is inadequate insulin administration. And why does this happen? Basically what happens is patients will be sick for some or the other reason. Their oral intake decreases, they stop taking insulin administration, and then this is a vicious cycle which sets in. The another area where diabetic ketoacidosis can present is patients with myocardial infarction, patients with acute ischemic stroke, patients with pulmonary embolism, patients with mesenteric ischemia. These patients can also have associated diabetic ketoacidosis. Cocaine abusers, they can present with DKA, and pregnancy itself is a risk factor for this. So the presentation would be patients at a milder stage will have anorexia, nausea, vomiting, polyuria, polydipsia. So these are little changes which are earlier. Then as they start becoming dehydrated, the skin turgor would go down, they would have dry skin, the mucous membranes would be absolutely dry, they will have small breathing and fruity breath, their breath would smell fruity in nature. The mental status will go down at the later stage of diabetic ketoacidosis, and then the complications. So they would present in hypotension, they would have acidosis, mostly lactic acidosis or just high anion gap acidosis, and then another features would be chest and abdominal pain. So what happens if you have to look at the pathophysiology, you will have an insulin deficiency and there is a counter regulatory hormone activity. And what does this do? This does lipolysis and proteolysis, and obviously it decreases the fat and protein synthesis. Now when you have an insulin deficiency, the other two mechanisms that would be triggered are gluconeogenesis and glycogenolysis. So it is trying to take care of glucose, and then the peripheral glucose utilization goes down. All these contribute to hyperglycemia, and because of the free fatty acid substrates gluconeogenic activity, this gives rise to free fatty acid oxidation, and this becomes converted to ketones, and so ketogenesis happens, and what we see is acidosis. So we have ketones as the reason for acidosis. Now hyperglycemia induces osmotic diuresis, and so the patients present with volume contraction and associated electrolyte losses. So what investigations we are going to do? Hyperglycemia, obviously when we want to label it as diabetic ketoacidosis, the first thing is the blood glucose level, which should be above 200. Ketonemia, so beta hydroxybutyrate, glycosuria and ketonuria, so you have those sticks, keto sticks available, dip it in the urine and see, so you will have levels of glucose and ketones. Acidosis has to be there in the blood gases, then only you will label it as ketoacidosis. So acidosis with anion gap, low serum bicarbonate, and the level should be less than 15, and moderate hyperosmolality has to be there. So if I have to give a differential diagnosis of various ketoses and anion gap, pH will go down in diabetic ketoacidosis, alcoholic ketoacidosis, uremic and lactic acidosis, whereas in starvation ketoacidosis, pH, anion gap and blood glucose or the plasma glucose levels are unchanged. Diabetic ketoacidosis, the glucose will go high because that is purely based in diabetic patients. The anion gap will go high in all acidosis except starvation. Serum ketones again are elevated in almost all ketosis, very high in diabetic ketoacidosis. And when you talk about serum osmolality, diabetic and uremic, they would have a higher serum osmolality as compared to other patients. The another subset would be type 2 diabetic, blood gas pH of 7.3, 4578 is PCO2, PO2, sodium 163, chloride 134, bicarbonate 21, glucose 1282. One is on a higher side, urine ketones are negative. Again, hyperglycemic episode, not so bad acidosis, numbers are very high but the ketones are negative. What is the diagnosis? Hyperosmolar, hyperglycemic hyperosmolar state, right? So this is mostly present in type 2 diabetics. Again, precipitation or the precipitating events are more or less the same as what we see in DK. So infection, ischemic events, stroke. This is characterized by hyperglycemia, dehydration, hyperosmolarity. But the important point is no acidosis, no ketones. So we are talking about no ketoacidosis here. If you have to categorize DKA and HHS, so DKA is categorized as mild, moderate, severe, and this is based on your pH levels, on bicarbonate levels. So the pH would be 7.25 to 7.3 in mild DKA. It goes down to 7 in moderate, and in severe DKA it is less than 7 or even 6.9. Whereas in HHS it is around 7.3 or above. Bicarbonate levels would be 15 to 18 in mild, in moderate up till 10, severe less than 10. But again in HHS the bicarbonate levels are still better, so they are more than 15. Ketones will be present in all categories of DK. You may find some ketones in HHS, but mostly it's a negative ketonemia state. Osmolality, obviously HHS will be higher. We saw sodium was 130, 163. So as such also the osmolality will be on a higher side because they are grossly dehydrated patients. And when you talk about anion gap, the anion gap keeps on increasing as the stages of decay increases. But in hyperosmolar state, anion gap is not there, or it's on the lower side, or normal anion gap, right? So this is the way you categorize them. Secondly, if you look at the clinical presentation, DKA happens suddenly within hours. HHS is a chronic and it has a very insidious onset. So patients will have signs and symptoms days before they present into that stage. So it's not an acute episode. Now, a 24-year-old type 1 diabetic presents to the emergency with nausea, vomiting for 1 day, blood pressure 94/62, heart rate 115, respiratory rate of 20, sodium 139, chloride 105, potassium 4.8, bicarbonate of 12, glucose 310. Which is the most important initial intervention? First, second, third, or fourth? Third. Right, so we would give fluid resuscitation to these patients. So whenever you are evaluating these patients, always look what is the precipitating event. Why did this patient come in DKA, or why did this patient come in HHS? So probably look for an infective process. Always assess the hemodynamic status, examine for the presence of infection, look for volume status and status of dehydration, because that will determine how much and with what rapidity you will administer fluids. Look for ketonemia and acid-base disturbance, because you want to differentiate, is this DKA or is this HHS. So the management is replace the fluid loss, replace the electrolyte loss, restore the acid-base balance, then replace the deficient insulin. Once you have done this, then monitor the glucose closely, look for the energy losses, try to feed them, see what is the precipitating event and how can you avoid such a recurrence in these patients. So when you talk about fluid resuscitation, normal saline is the fluid of choice in the early stages, and you do a 500 to a liter per hour of fluid boluses. If the urine output is good and your sodium levels have improved and they have gone more than 140, you can change 0.9% saline to 0.45% saline, right? And you can also decrease the rate of fluid resuscitation. Once the blood sugar level goes below 250, that is the time you want to add dextrose to your resuscitation fluid, and you change to either a DNS fluid administration. And the target is you want to decrease the hematocrit because they are grossly dehydrated patients. On an average, DKA patients will be 5 to 6 liter deficient, and HHS patient will be 8 to 10 liters deficient, right? So they are hyperosmolar as compared to DK, and they require more aggressive fluid resuscitation. So the recommended schedule is generally administer 1 to 3 liters in first hour, then 1 liter in the second hour, then 1 liter over next 2 hours, then 1 liter every 4 hours, and you keep on assessing the degree of dehydration. And what you want to target is good urine output and decrease in hematocrit, right? These are the two targets that you are always looking for whenever you are resuscitating these patients. The second thing that you will administer is insulin. So regular insulin, 0.15 unit per kg bolus as an intravenous bolus, and then you start an infusion of 0.1 unit per kg per hour. We will continue this till the ketones in the urine get resolved. If the blood glucose level do not come down by 50 to 70 milligram in the first hour, the dose of insulin infusion is doubled, right? So if this is not coming down by 50 to 70 milligram in the first hour, double the dose, and we eventually change this into the subcutaneous form when the blood sugar is below 200, pH is better, bicarbonate is better. So basically patient is getting adequately resuscitated. So what is the role of insulin? Basically it is required for transport of glucose into the muscles, adipose tissues and the liver. It also inhibits the lipolysis. If there is absence of insulin, the glucose will accumulate in the blood. It would use another sources for energy, so it would start using amino acids for gluconeogenesis, and again it would convert the fatty acids, the free fatty acids, into ketones, acetone, acetoacetate and beta hydroxybutyrate, that is what we test, right? So absence of insulin will give rise to ketoacidosis. Now this DKA patient was treated with saline, a bolus of regular insulin and insulin infusion. The glucose has decreased to 180. Bicarbonate is 15 and anion gap is 16. Which one of the following is the most appropriate intervention at this time? Is it 1, 2 or 3? 1, right? You will now change your fluid. So saline has been done and you start with a dextrose containing fluid. So you will start DNS, but you will not touch your insulin infusion, right? You will not touch your insulin infusion. When you talk about HHS, glucose significantly decreases just by fluid resuscitation, specifically when I am talking about HHS. Here insulin is required, but fluid resuscitation itself decreases blood glucose levels. Again, the loading dose will be 0.15 unit per kg. We would require infusion of a lower dose insulin. Here the insulin requirement goes down as compared to DK, and decrease the insulin infusion to keep glucose at less than 300 until the sodium level decreases. Remember that, because here the sodium will be on a higher side. It's a hyperosmolar state. Till when will we continue? Till the time following 3 are not achieved. There has to be a clearance of acidemia. So pH has to go above 7.3. Bicarbonate levels have to be above 15 and anion gap has to close. Remember that. We are not talking about disappearance of ketones. We are talking about closing of the anion gap. That is the most important point. So insulin infusion will continue till the time you are achieving these 3 phenomena. So the same thing as I said, once you look for 2 things, you are looking at the volume status and you are also targeting your blood sugar. So when you are looking at your volume status, if the patient is severely hypovolemic, you administer 0.9% saline. Patient is mild hypovolemic, you look for the sodium and correct it accordingly. And if the patient has cardiogenic shock, right, then you would do your hemodynamic monitoring and your vasopressors and so on and so forth. Once you have evaluated your sodium, if the sodium levels are on a higher side, your 0.9% saline gets converted to 0.45% saline. If the sodium levels are low, you continue with 0.9% saline, and once your blood sugar reaches to 200 or 250, you change your normal saline to a dextrose containing fluid, so that would be a DNS. Yes, you would keep on checking your electrolytes and pH and everything, and after resolution of decay, encourage the patient to eat. When you talk about insulin, we start with an IV route. So you give your bolus, you start your infusion. Once the dextrose starts falling by 50 to 70 milligram per deciliter in the first hour, you are okay. If it doesn't happen, you double the dose. Remember it. And once it reaches 200, you start decreasing your infusion rates so that you keep the blood glucose at that level. Now the transition, you are giving an IV form, you want to continue, you want to shift to a subcutaneous. So start regular insulin every 4 hours, but once you are overlapping it, continue your insulin infusion as well for first 1 to 2 hours. So that's an overlap that we are talking about. So overlap infusion with subcutaneous insulin for 1 to 2 hours, because you don't want the fluctuations in the blood sugar levels. Use lower dose of intermediate or long acting therapy, and type 2 diabetics would require insulin for a longer period of time as compared to the type 1. Then correction of acidosis. Insulin therapy stops lipolysis and it promotes the metabolism of ketone bodies. So this together with dehydration generally normalizes the pH. Bicarbonate therapy administration has no role in diabetic ketoacidosis. Even at a pH of 6.9, don't administer bicarbonate boluses. There has been no studies which have proven any benefit. We generally administer at 6.9 only and only if hemodynamic instability is also associated with this. As the acidosis is corrected, urine ketone body starts to appear in the urine, and rising level does not mean my patient is bad. It has no prognostic value. So again, if the urine ketones are increasing, don't get worried. What are we worried about? Anion gap. So if you are giving insulin therapy and your anion gap is closing, this means your patient is getting resuscitated. Urine ketone bodies has no prognostic value in decay, so don't target that. 32-year-old type 1 diabetic presents with weakness, blood pressure 114/70, heart rate 100, respiratory rate 20, ABG, pH of 6.94, PCO2 of 10, PO2 294, sodium 139, chloride 105, potassium 2.5, bicarbonate of 5, glucose 568. After a bolus of saline, which is the next most appropriate step? 1, 2, 3, 4. 3. Right? 3. Why not 4? Because insulin will drag the potassium inside, and as such your potassium is 2.5 and your patient has weakness. Right? So first correct the electrolyte. So if your potassium is more than 6, do not administer potassium and start with your insulin therapy after your fluid resuscitation. If the potassium is less than 3.5, first correct potassium. So add 40 milliequivalent if you have a central line grade, if you have a peripheral line, add it into the saline fluid and hold insulin till your potassium is above 3.5. Certain books have written 3.3 also, but 3.5 is generally the accepted norm. If the potassium is between 3.5 and 5.5, 20 milliequivalent per liter has to be added. Always keep on checking it. Replete hypophosphatemia. So generally what it does is, now you have an IV potassium and phosphate available. So you can add 30 to 40% of potassium as a combination of potassium and phosphate to replenish the hypophosphatemia. Don't give bicarb. Why? It will again push the potassium inside and treat the underlying cause. So the same thing, if the pH is less than 6.9, then only look for bicarbonate, but again please correct the potassium before that. So if potassium is less than 3.3, replace till the time you reach 3.3. If the potassium is fine, you start your insulin infusion and you continue accordingly. Then bicarbonate. Patients tolerate acidosis very well, at least DKA patients, and no documented benefit with routine use. Consider only if the pH is less than 6.9 and associated hemodynamic instability. Do not try to normalize the pH by administering bicarb, and even if you have to give, use infusion rather than pushing a large volume of bicarbonate. Infections are generally the most common precipitating event, so plan your antibiotics accordingly. Look for a broad spectrum antibiotic to start with, and once you have a culture reports, narrow them down to the most specific antibiotic. Complications: shock only if myocardial, you can suspect myocardial infarction if these patients are not settling with IV fluids and cardiogenic shock is the cause there. Vascular thrombosis: because of severe dehydration, these patients can have vascular thrombosis. Specifically, patients can have superior vena cava, patient can have cavernous sinus thrombosis as well, and this occurs hours to days after decay. Pulmonary edema if over-aggressive fluid administration is done, and cerebral edema because of sudden change in osmolality, sudden change in sodium levels. So these patients can have life-threatening cerebral edema. Thank you.